Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice in any situation. Please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you're unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome back to another episode of Glasses Half Full. Today we will be discussing putting the power in the hands of the patient. So when it comes to patient empowerment, what do we mean by that? What I think we mean by that is making sure that the patient is in control of their own health and their own body, and in our domain, that's eyes. Okay?
Yeah.
We've been educated and taught how to check things, how to diagnose things, how to treat things, so on and so forth, but it is the patient's eye. And we need the patient to learn and know how to take care of their own eye to as much as they can. You know, there's certain things that obviously they can't do unless they have a slit lamp at home. But yeah, there's a certain amount that they can do.
So when you say patient empowerment, with sort of decision making to do with their own eyes and their own ocular health and all these things, the first thing that comes to mind is to educate the patient. They can't be making informed decisions until they are informed of what's happening to them, first of all. So if a patient doesn't know, for example, what a cataract is and why a cataract is developing and why he needs to have it removed at surgery, he can't possibly
consent to get it removed.
Consent to a surgery to remove it. You can't say to them, sign here for your surgery that we're going to take you to, if he doesn't know what's happening to him. So, I mean, from the early sort of signs of the beginnings of cataract, the patient should be told this is what's happening, it's in its early stages, so that by the time the cataract has progressed, they know what's happening and they know what to look out for. I mean, the best example of that was a patient came into me having had both cataracts done, and they had PCO in one eye. They've already had YAG in the other, and they came in saying, it's happening again, send me to Spa Medica so I can get my second eye laser sorted. Because they had been so well informed in the past of what the PCO was and why it had developed that they could make a decision straight away before they even tested.
I had a similar patient today, actually. They came in post-cataract, and then I was discussing with them about possible PCO developing. And when I discussed it, I'm like, yeah, I already know that they've already told me all this. I was like, well, great, because you already know what to expect. So like, if you have any of that, just come back and we'll refer you onwards, basically, if that's needed.
I find that it's so helpful when the patient's fully aware. For us, it's super easy.
Yeah.
We've spent so long knowing cataracts, uveitis, so on and so forth. I find that oftentimes it is, for example, somebody who's had it prior, like your example with the cataract, etc. I can think of many times where I've had a patient that's had uveitis or something like that, and they're like, oh, it's happening again. They catch it a little bit earlier, and it's so refreshing, but they shouldn't have to have had it to know what the problem is.
Yeah. Not obviously, if somebody's had a retinal detachment for the first time, they can't. But if somebody comes in as a high myope with
knowledge that
-7 and they say, oh, it's happening, because all of their life they've been told, watch out for flashes and floaters. That's exactly what we need to be doing.
That's exactly what we need to be working on. And letting patients know for things that, okay, we can't prep everybody for CRVO, okay, and that's fine, okay, but for things like cataracts, for things like presbyopia, for things like macular degeneration, which have a much higher likelihood of developing,
and have warning signs earlier.
Exactly.
Yeah.
Exactly.
The thing is there's a variety of different eye conditions, but a lot of the eye conditions that we are accustomed to explaining to the patients, they're more long-standing conditions. So like cataract, for example, you don't suddenly, unless it's like traumatic, you don't suddenly develop a cataract.
You don't wake up with one.
Yeah, exactly. So you're kind of like building that kind of knowledge base every time you see that patient. So you don't need to tell them about the surgery the first time you see mild nuclear sclerosis, but you tell them when their vision's at like 6/12 and they need to be referred. It's like, this is what we're thinking about.
Well, you wouldn't tell them the ins and outs of the surgery.
No, that's what. Yeah, that's what.
You'd mention maybe that eventually you will have a surgery.
You'd mention the pathway in which the treatment options are for progression of the condition.
But you wouldn't. You'd say it's treatable. We can do something about it. Don't worry about it. But that's a conversation we'll have another time.
Yeah. I would go like, there is a surgery that can be done, but at the moment you're perfectly fine.
Exactly. We'll cross that bridge when we get to it.
Yeah, exactly.
But it's about laying the foundations for that conversation.
Perfect.
Because there's nothing worse than coming in, and seeing a patient who's 80, they've got macular degeneration, cataracts, they've got all sorts.
And
of
then you
things
tell them all
happening.
like, what?
And then they say, "Well, what's this? What's a stigma?" And you're like, "Right, you've got 3 silk."
Yeah.
This has been long-standing. Why has nobody said this?
Why are you wearing red readers? Yeah,
For the bleak cells, yeah.
That's the thing. They're not. It's when it comes to on that point, cataract surgery. I make sure the patient knows everything that they want to know, but I find it puts patients entirely within the right. Yeah, when you start explaining cataract surgery, they're going.
I don't explain the surgery process unless they like physically ask me.
That's what I'm saying.
Like, but when I say about the surgery, I usually talk about the process that they're going to go through within the experience that they should expect.
Oh, as in, I'll see you now. They'll see you for an assessment.
Exactly. Yeah.
They'll do the surgery. There'll be a 4-week follow-up, and then you come back. And
I mean, I'm talking about a separate point. Like,
oh, you don't like talking about.
I don't
scary
like talking
things.
Because the amount it puts the patient off, and I completely understand that. Oh yes, like when you start, like when like, oh, they're gonna cut into my eye. Like, how do they take it out? Do they use lasers? I'm like, well, they use ultrasound to break it apart, but then have to replace it with a plastic lens.
Oh no, I say they go in with 2 really small tools. They put in them in drops. Yeah, 2 very small. 2 very small tools, like the size of a pen. And it takes 20. I usually I don't go into the specifics of the phaco and everything. What I say is it takes about 25 minutes.
Yeah, like if I can
if you're slightly late, the surgeon will be a note that he's late for lunch. That's how quick it is. Yeah, you'll go home the same day with drops.
Yeah,
and in a month's time you'll be back.
That's what I try to keep it to. In and out same day, local anesthetic. You're on the bed for 15 minutes, and then so try to keep it as simple as you can. But
you've obviously got to mention the risks, and you've got to say that there is a 1 in 10,000 chance of you losing sight or your eye.
Well, actually, I don't think you're clinically required to say that.
Oh yeah, of course, no, you're not.
I feel that should be brought up prior. Okay, that should be brought up when you're trying to avoid, because obviously we try to go for the least invasive, highest band treatment possible. And for as long as we can with size for improvement, we will give glasses, and I think that's why we will give glasses, because if someone's like 60 and they're having reasonable development of cataracts, in all likelihood, eventually, if they live long enough, eventually they'll have to get the cataracts taken out. So one could argue, or a patient could ask, why don't we just do it now? But
I've had people asking that.
But you'd say because the risks outweigh the benefits. You're not going to notice it that much now, and it's a surgery with low but somewhat risk.
I say it's a very safe surgery, but it's still a surgery.
Precisely.
That's what I say. And then they get the point.
But yeah, I mean, all of this just comes into sort of educating the patient of the risks and benefits. And I know we honed in on cataract surgeries, but even from the smallest things, you can't say the patient declined to have multifocals if you haven't explained to them what the benefits and the disadvantages of each lens option are. So you have to tell them that if you want great clarity of vision for reading a book, readers are going to be better.
Yeah.
If you want to be able to read your book and look up and look at the telly and check the clock on the wall, you've got to have some kind of multifocal. Or
half of my day is explaining varifocals. Honestly, and the amount of people that I've heard a bad experience from a spouse or friend, so on and so forth, who can get on with it for whatever reason, and that puts them off, and it's like,
but you've not tried it.
The vast majority of people get on with it. Vast majority of people go on with it.
Especially if it's done properly. Because in a lot of cases, because varifocal is very height sensitive, and the type of varifocal varies on how well you get along with it, it is very dependent on those kind of factors as well. So in a lot of cases, people that can't get along is most likely because A, the varifocal is not that great, or B, it's not fitted properly and they're just not being bothered to go back to complain about it, and they're just sitting there saying it's crap.
I feel that something for so we're getting on to a little bit of a different point than education now. It's sometimes a patient I have family members who are presbyopic, and I tell them varifocals are fantastic. You just need to get used to them. You pop them on in the morning, and you can see everything. But they just don't like it. They just don't want it, so on and so forth. And I know that they know exactly how varifocal works, but I've spent a long time trying to get them to do it. Far too long. And you know what? That's entirely fine.
Well, yeah, of course.
That's entirely within the right.
But that's the whole point of this topic, I guess. Is when you're discussing it with the patient. Like, for example, if someone's like a full-time single vision distance wearer and they're struggling to read, I'm like, well, because you wear glasses all the time, or spectacles all the time, personally, I think you would benefit from wearing a varifocal or a bifocal because you're able to do all the
What
tasks.
you're doing right now.
What you're doing right now.
Plus a bit of reading.
Basically, you'll be able to do all the tasks that you want to do without having to swap between glasses. However, if you want just 2 separate pairs, that's also it'll work perfectly fine as well for you. It'll just be a bit annoying because you'll have to keep swapping between them. That's what I would tell them.
And I think that's where it comes to the education point, is just because you've seen somebody who's a established distance and read in separate pairs, doesn't mean that you can't have the conversation about why haven't you had varifocals in the past? Why do you not want them? It's not a pushing, it's not a sales conversation where you've got to push it down their throat, but you've got to say, what's the reason that you've not had them?
I think a lot of, just to add on to that point, is the reverse is also very viable as well. Like, you have a lot of patients. This is more in the more older patients that have relatively lower vision, lower VAs basically. They're on varifocals because they've been on it for ages, but now they have
since they were working and they've now retired.
Exactly.
They either read a book or watch telly.
Exactly, but the thing is like they're on varifocals and their vision's like 620 and like N10 and N18 or whatever reading is, but then they're wearing varifocals. But you're like, maybe single vision distance and readers might work better for you
because you get a better clarity of vision.
It's optically better for you.
Lens, exactly.
So it works the reverse way as well. It's a matter of telling them what your options are and then letting them decide based on your advice.
And not just trusting because they've been a historical varifocal wearer or a historical single vision distance, single vision reading, that they want the same again. They might want a bit of a change. They might just want to have that conversation. It's about informing them of the benefits and the disadvantages of every lens option available to them and letting them make
not necessarily available, because I mean
suitable,
everything's available,
suitable for them.
Suitable for them. I think is the better word to put it down, because you wouldn't want to like discuss, I don't know, like lenticulars to a patient, would you? Unless they actually need it. Unless they actually need it.
Exactly, of course.
Yeah, so it's a matter of, I think, I'm being pedantic here, but suitable, I think, is a better word, because you're deciding what they need to know to make the informed decision.
Yeah. I mean, there was one today who had 4 differential base vertical in both eyes, distance and reading.
Yeah.
And he was in separate pairs, and he was saying how his wife has varifocals and she really loves them. And I said, why do you go for varifocals? And my brain had not processed the vertical 2 up, 2 down prisms. I said, yeah, why not? Let's go for them. And then I had a quick word with the DO, and I came back into the room and said, actually, let's not do that, because if you do, it's going to be,
you could do bifocals though, couldn't you?
Yeah, but the varies would have been in the realm of special order, and I said to him, you can't go for it.
Yeah.
The cost is going to be very high, and there may be problems with it.
I would.
Should we just stick with the separate ones? And he said, yeah, I'm happy with that.
I personally discuss bifocals a lot, because it's better. People get along with them more easier than a varifocal, so I discuss with it a lot.
It's not the only time. I exaggerate. Oftentimes, I discuss bifocal as opening part to get them more open to wearing varifocals. Because it's like, hey, listen, varifocals, sure, they sound a bit old and all that stuff.
Yeah.
But they're not bifocals, are they? It's like, yeah, they're not bifocals. They look normal, they look normal. So I'm like, oh, they're not got that line in them.
I usually use bifocals as a point to people that don't like that aspect of varifocals where you have that distortion at the edges, or more someone that wants the multifocal part of it, but for some reason they struggle with having a varifocal. So in your case, a prism. In some cases, an isometropia, a bifocal would work much better.
Also, I find that varifocals works better for the modern kind of employment situation where somebody's got to be so flexible with a task, reading small print, VDU, distance, whereas somebody who's retired and their multifocal requires reading a book and watching the telly, doing their crossword.
And there's less precision required with the bifocal, because you just need to look in that segment and you've got your reading. So it's not necessarily doing this anymore.
You shouldn't be doing that.
I mean, you shouldn't be doing that. But the thing is, it's very common in varifocal wearers that they are doing that, especially when they first started wearing them.
Well, yeah, but you get used to that after 2 weeks, and then
you're
not doing that anymore.
True, they shouldn't be doing that, but a lot of them do.
Hopefully not that many.
The amount of patients like it comes like, I'm doing this to read. I'm like, well, that's not right.
No, that's absolutely fine. If they're lifting their head to read to see out of a lower portion of it, then you just need to increase the strength a little bit.
All over the corridor thing.
Okay. Yes. Or change fitting, etc.
Yeah.
but that's never by design.
Oh yeah.
That's it. Thanks for joining us for another episode. Hope to see you next time.